friends, young friends, and people who have been in the field from some time. I really welcome you wholeheartedly. So last month we covered matrix, which is an adjunct to the type of therapy we use in cerebral palsy, and how we really looked at how we could walk the way using matrix as one of the adjuncts. When I look at situations and I look at how the kids whom I'm seeing yesterday, this was exactly yesterday. Now this little one, I will show you his video in some time, has come back to us after a span of almost a year. The family did try taking online sessions, but the parents did not understand what to do on online sessions. So they said, no, we don't want to take online sessions. And so you can see the amount of crouch this little one has gone into. He is now going into adolescence. He is maturing into a young adult slowly. So a lot of factors really go berserk when you see kids who are entering their teens or are pre-teens, maybe at 10 years, 12 years. So the growth spurts which happen in this age group, one growth happens at 3, one happens at 5, one happens at 7, then at 11. So when you see these kids at this age, you see that they are really very difficult to handle. So their participation becomes very important to them. In a country like India, participation is this is the age where they are put in a backward phase. कि अभी उसको घर पे रख देते, इतने साल हम लोगों ने किया, we have done therapy for so many years, अभी बस हो गया है ना. So 7 years when they see the child growing up, the child becomes taller, and the parents feel कि the condition is worsening. Walking the road today, we'll see actually the condition doesn't worsen. It is the muscles and joints which show a different picture. Their gross motor activity skills, their mobility skills, their functional skills all undergo a challenging situation. And impairments, everyone feels spasticity is the problem. But it is not spasticity which is a problem. The main problem is the range of motion limitations. You have liver arm dysfunction. So all this is something which we are going to go through and see whether manual therapy has some answer for these or a solution for these problems. Personal factors, if you see their motivation definitely dips down a little because parents are talking around them. ये तो नहीं हो रहा है, बात नहीं चल रही है, they are not walking. So some of them are the lucky ones who are motivated parents and say, कुछ नहीं, we will go, we'll walk the way. These are the kids who really do well later in life. They have been giving Botox in and out. Possibly surgery has been done in many of them. So priorities and goals become very different at this age. Safety concerns are also are a point which we should remember. And one, as a therapist or as a caregiver, has to be aware of the immense potential these children carry in them. The accessibility towards many things, right from transport to staircase. You saw that little one. I show you his video, and you see how difficult it is for them to even step forward. Opportunity and availability of adjuncts in India is a big challenge. Support, very few people get the support which is required, and teacher and peer attitude. So how this really affects our children and how do we go about it? So as we all know, as working therapists in pediatrics, that postural control is an end result of many factors. Okay, so this is a dynamic systems model which we look at when we are looking at a CNS pathology like cerebral palsy, which causes a loss of connections. There are negative features, and there are positive features. Positive features is all what we see: spasticity, clonus, co-contraction, child is stiffening. But the other factors are less looked at, which are weakness, fatigability, poor balance, and sensory deficits. All this leads to an affection on one of the single most major system which contributes to growth, and that is the musculoskeletal system, where muscles are shortened, there is bony torsion, there is joint instability, and there is degenerative arthritis, very early degenerative arthritis which sets on. So looking at the primary injury, wherein there is tone affection, there is balance, there is strength selectivity which is affected. There are a lot of coping strategies, compensatory mechanisms which these children develop and result into either misalignments, malalignments, rotations, malrotations, lever arm dysfunctions, or fixed contractures. So you have the learning stage, which starts very early, goes on to 7 years where they sort of plateau, and then their activity, function, and participation in adolescence actually goes for a toss. And people say, oh, it's very difficult to deal with these kids, but it's not difficult if you know, if you have चाबी अगर हो तो लॉक खोलने में कोई प्रॉब्लम नहीं. प्रॉब्लम वही होती है कि एज थेरेपिस्ट वी डोंट नो, वी कीप सेइंग अरे ये भी ट्राई करो, वो भी ट्राई करो. You cannot do that. You have to be completely goal oriented. You have to know your patient in and out. You have to know which muscle is affecting, which is the one which I can target. So these are known and unknown factors. Now this is one important thing. Paint तो लगाया होगा घर पे सबने. Everyone knows that when you're renovating a house and when you're painting your house, what happens to the paint box? You see the paint is the first day when you see, wow, what a color, what a texture. After a few days, when you're painting the wall and you say the painters are taking a holiday for 2 days, and you see that the paint box actually has a thickened layer of paint on it, and the moment you put the paint brush or you put something knife inside to see a paint theek hai ki nahi, inside it is all liquid. So this is exactly what happens. Anything which is not used, any there's a loss of osmolarity, as it is called. So this is called as Thixotropy. It is the history dependent change in fluid viscosity. All of us know our textures, our body is made of 70% of water, and definitely the fascia, which envelop the muscles or envelop the body from up to down, it is called as myofascia, is completely dependent on this fluid component to retain its dynamism or the stretchability. So in our kids, number one, they do not have that much amount of mobility. They're all static. Plus, they drink less water. So there's a contraction of the fascia, it becomes tight. And the longer the applied shear forces, the lower the viscosity. So this is what we call as muscle thixotropy. And this is the term which we use for history-dependent changes in the so-called short-range elastic component. A growing child is also similar. We have unbalanced opposing muscle structure and forces, which result into opposing muscle tendon unit shortening and lengthening. Now, fixed abnormalities then guide the skeletal development in an abnormal manner, causing multiplanar deformities, including torsional abnormalities. So you can see gravity plays a major role. Gravity जो है ना बहुत अच्छी चीज है और बुरी भी चीज है. You can see that this is a muscle. This is a typically developed muscle and a spastic muscle. There's a lot of change which happens in the collagen, endomysium, muscle fibers, fiber bundles. You can see the fiber bundle diameter in the typically developed and the spastic muscle. So there are changes which happen, which come very in small. एक छोटी छोटी किश्तों में आते हैं ये changes, and you don't suddenly see it. You see it over time, but parents don't notice it because it's a very small change which happens. So the effect of spasticity: muscle that has few fibers, short fiber length, and longer tendon. Excuse me for the longer angle हो गया वहाँ पे, longer tendon. Weak muscles, diminished excursion, cross section area becomes less. Their range of motion is reduced. And what muscles need actually to grow? They need a elongated component. You have to have that elongated component in activity to grow, which does not happen. So you see that most of the muscles which are affected are the big muscles. And do we have anything what we can offer as NDT therapists? We do NDT, but we cannot stop these muscles from undergoing the changes what are seen. So this is what happens. You can see a typical development, and you can see a child with cerebral palsy. See the muscles which are thinning out. You can see the cross section here as opposed to the cross section here, and the static and dynamic components which happen. So coming to LAD, that is lever arm dysfunction. It is disruption in the movement generation of a muscle joint complex because of ineffective lever or movement arm despite normal muscle force. LAD is also defined as a set of conditions in which internal
Your voice is breaking.
my voice is breaking. Should I go to Snehal or Snehal extension then? Let Is it good now? Is it better?
Yes, much better.
Yeah, thank you. So looking at my mobile actually gave way when I came inside the room. That may have happened. So when you see, the most important factor we saw was Newton's gravity, which he discovered that light can work in a bad way. So it is like a sword. A child can use it both ways. When you use it well,
Ma'am,
it
I
can.
think
It is
previous
a
connection
double-edged
was
sword.
better
So
because now the voice is breaking more, and maybe you can go to the previous connection, and maybe the nearby people, those who are using the same connection, they should disconnect themselves. The
no,
previous
they are not here. They are not here. They are in another room.
previous connection was
Yeah,
better.
okay. Check now.
And we can hear you, but we can't see you properly. The video is not coming properly.
That's fine, ma'am. That is fine.
Yeah,
If
yeah.
it's
We
for
can
That's
PowerPoint,
okay. Now you can
still
hear me. Now you
continue.
don't need to see me.
Yes, yes.
That's okay. Okay, you can see the pictures what are there. That's why the slides. So one factor is gravity, and the second is the ground reaction force, because the body has to act against gravity. So the body has its extrinsic and its intrinsic mechanisms, which it has to work against gravity. And one of the important ones is the ground reaction force. Now, when the ground reaction force in the previous talks which we had last year, we have seen how it causes and its deleterious effects on the bone levers, okay, and also basically on the foot and the lower extremity. So whenever you think of managing a child with cerebral palsy, a child who has spasticity, we think of the effects which are seen in the lower extremities. So children with, now coming to, I think we'll go to Deepak sir now and then come to the how much, when, what, contraindications a little later. So going into what happened was, when I attended Mulligan's with Deepak sir, and I'm very happy to introduce Dr. Deepak Kumar. I don't think any one of you wouldn't know him. Dr. Deepak Kumar is one of the most uh, highly known persons in and dynamic persons in physiotherapy in India, and he is a manual therapist and he leads the Capri Institute of Manual Therapy. So what incidentally happened was, after I attended the Mulligans, I said, why not try these on our kids? Can we do that in our adolescent children? So we did a few in Delhi. When I had gone to Delhi, we decided we'll do a few kids there, and we did a few kids, and we saw good results. Now, of course, when good work is seen, we said, why not do it back home here? And that's how there were few of the therapists who had done Mulligans from the workshops, and we started doing Mulligans in Mumbai here, and we saw wonderful results. So our paper also got published in one of the international journals, and we would now like to invite Dr. Deepak Kumar to talk about it. After he finishes, I come back with what are the contraindications, how many times you can give, etc., etc. So over to you, Dr. Deepak.
thank you very much, ma'am, and thanks for the lovely introduction. And in fact, it's a privilege and honor to be associated with Snehal. And this probably started 10 years back, if I remember correctly. And
You're right,
mm,
almost.
yeah, almost 10 years back. And then we tried certain techniques on kids, and the result were amazing. Like earlier, people used to ask whether it's going to work in pediatrics or not, or in CP or not, and I used to say I have no idea. And when ma'am came in my contact and we discussed this and we tried it on CP children, the result were really amazing. One of the incidents I remember, we gave to one of the child one of the technique, and because the child was having habit of walking with this spasticity, and after this technique the spasticity reduced to a drastic level, and the the patient was it was very difficult for the patient to manage, like, because he was not prepared for the so much of relaxed muscle, so much of reduction in spasticity, and the patient was about to fall, and we have to hold him, and then in few minutes patient got used to it and walking much better than just before the technique we gave. So that encouraged both of us a lot, and then we did some studies in Sinhel itself, and the paper got published. So the three main techniques which are very very beneficial for the cerebral palsy cases, I'll show you all those three cases. I'm going to show you the pre-recorded video so that you get the best angle and the uh, view, uh, so you understand the technique completely rather than me doing the live demonstration, because in live demonstration you don't get the perfect angle. And I like the terminology which Snail madam just explained, Thixotropy. That's a lovely terminology I liked, and probably we are working on that. I was wondering how come we are getting such a lovely, beautiful results, but probably we are working on that Thixotropy kind of mechanism, and we are giving sustained stretching, and we all know that sustained stretching always help in reducing the spasticity. So in this we are giving sustained stretching along with the traction with the long axis of the muscle fiber, and then we are also touching firmly, and then we are giving the traction along the long axis of the muscle fiber, and simultaneously we are stretching them. Probably it is the combination of all of them which is helping in increasing the range of motion and reducing the spasticity. And the technique which I'm going to show you, it not only helps in increasing that specific range of motion, but we did this study even on normal healthy individuals. In fact, the subjects were physio themselves, and we did these techniques on physios in a controlled group and experimental group. 30 were on the control group, 30 were on experimental group. And we noticed that it was not only the abduction or the SLR, but it was the internal rotation of the hip, external rotation of the hip, flexion, extension, abduction. Everything got opened up as compared to the conventional stretching. So let me show you the videos without discussing further. And if there's any question or query, probably you can ask at the end of the session. Me or Snehal ma'am will try to answer your query. So let me start my videos. Hi, in this chapter, we'll be discussing again how to treat patient in case the patient is having tight hamstring or radiating pain in back of the thigh. So in this technique, if it is permissible, if the limitations are not there, if the patient is not osteoporotic, if the patient is not osteopenic, if there is no hip pathology, I'll prefer not to do these techniques in elderly patients. So check out all those contraindications, especially related to the hip joint. Then I'll be doing this technique. This technique will look quite aggressive, but actually it is not. It's very gentle. So what I'm going to do, I'm going to take the affected leg into hyperflexion. I'll be bending knee fully and then put hip joint into flexion. That means I'll be taking knee almost towards the shoulder of the patient. If in between while doing this procedure, patient complain pain, I'll be putting hip joint into abduction and external rotation. While doing this technique, I will also be giving traction along the long axis of the femur, and this traction will be sustained throughout. Usually you don't need second physio to stabilize the patient, but in this video I'll prefer to use second physio to stabilize the patient, so that those who are seeing this technique first time, they don't get scared of doing this. Don't worry, patient will not fall of the table, though it looks like as if he's going to fall. But don't worry, in last 28 years, patient never fell from the table. So you can be relaxed. As I said, technique looks very aggressive, but it is not. It is to be done very gently and in a coordinated way. Talk to the patient constantly and don't extend the knee while performing this technique. The reasoning why patient is getting result will be discussed after performing this technique in a short while. Till then, enjoy the chapter, enjoy the technique, learn it properly. So you take the patient on edge of the bed and imagine this is the affected leg. That is the right side of the leg is the affected one. So in case patient is having too much reduced SLR, so I will do the hold relax technique in the initial range. Push my hand down and relax. Push it again 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 and relax. And this is how you can come up to this range very comfortably. And then you are going to put the knee joint on your shoulder. Okay? And patient can hold the table there and one hand can be there. Now make sure knee must not get extended. Your shoulder shall be in the popliteal fossa, not under the calf. So stay in the popliteal fossa and with both hands you are holding the lower end of the femur from the medial as well as the lateral side. And before you perform the technique, as I said, actually it is not required, but on safer side for this video because you are probably seeing it first time. So I'll take the help of another physio to stabilize the leg. And now I'm giving the traction along the long axis of the femur and then going there and constantly talking. Is that fine to you?
Yes.
Imagine if the patient says no, it is not fine, he is having pain. I'll ask him to push me back gently. Push me and relax. Push me and relax. Push me and relax. And still if that is not helping, I will go for abduction and external rotation of the hip. And then again push me and relax. Push me and relax. Come on. Push me and relax. Push me and relax. Push me and relax. And maintain the traction while coming back. And then check the SLR again. You should compare the SLR before and after the technique and you'll be amazed to see the difference. So now if you notice, in this case, I took the knee almost beyond shoulder. But when you do on a real patient, maybe on day one, you will not like to cross that limb. Or if you're doing on a acute pain, maybe just doing up to this level is more than enough. Beyond that, you don't want to go. So you will do this technique essentially in a pain-free way. To remove pain, you're going to sustain the traction. You may do the hold relax. You may add the abduction and external rotation at the hip joint. And if after doing all those things still patient is complaining pain, that's the end range for that day for that patient. Maintain that traction and come back and just do 2 more times. That's it. Total 3 times you're going to do. That's it, not more than that. And next day you will be surprised that patient will say less pain. In fact, the patient will say less pain and the SLR will increase instantly then and there. So this is a beautiful technique for tight hamstring as well as for radiating pain in the course of sciatic nerve. If the patient is having tight hamstring, which is usually on both sides, so of course you will be doing on both sides. 3 times on this side and then 3 times on that side. And the SLR will increase immediately, instantly, then and there. Make sure you check all the red flags and yellow flags. And now I'm sure you notice why did I say the total hip replacement is a contraindication for this particular technique, or the osteoporosis is absolute contraindication. DHS will be a contraindication. Lose a metal implant in the hip joint will be a contraindication. Elderly patient will be a contraindication. Elderly means above 60 or 70 years. don't do on those patients. Do it gently, slowly, in a pain-free way. Let me demonstrate this technique once again. So I request therapist to again stabilize the leg, bend the knee, and you know how I reach there. Okay, push my hand back and relax, push my hand back and relax, push my hand back and relax. Once you reach this range, you put your shoulder under the popliteal fossa, give the traction, maintain that traction. If you are feeling resistance, ask him to push it. Come on, push me and relax, push me and relax, push me and relax, push me and relax. And if patient is complaining pain, you give more traction, abduction and external rotation. Again push me and relax, push me and relax, push me and relax, push me and relax. And then in the end range, you can hold it for 20 seconds and then maintain the traction and come back and then check the SLR. So basically this technique is recorded for the purpose of orthopedic patients. But the same technique we have tried on CP children and it worked beautifully. And I was quite encouraged by use of this technique at Snehal, which ma'am used it very often, very frequently on her clients or the children's, and we get beautiful result. But if you notice, this video is recorded from the point of view of orthopedics, and next two videos also recorded from the point of view of orthopedic patients. But same thing you can use in spastic children also. Let's start the next video. Okay. Hi, in this chapter, I'll be discussing and demonstrating how to increase hip extension or knee flexion in case it is affected because of the tight quadriceps muscles, or how to stretch quadriceps muscles. This is a beautiful technique, pain-free way of increasing range of motion at hip joint and knee joint and maintaining the stretchability or the length of the quadriceps muscle. Again, you will do just 3 times. At the end range, you can give passive accessory movement or you can hold it for 20 seconds. Procedure is again absolutely pain-free. If it is painful, you are going to add more traction along the long axis of the femur and add abduction and external rotation at the hip joint. You will need one more therapist to stabilize the patient firmly on the plinth, and you will also need a belt, treatment belt, so that you use the body weight instead of using your energy. You use the body weight. It's a strong technique, so do it gently. Use the body weight, don't strain yourself. Check for the yellow flags, red flags and the limitations. Again, total hip replacement or the total knee replacement will again be contraindicated because it's a very aggressive technique. Patient will be in the sideline position with the affected leg on upper side. So you will take the patient in the sideline position, affected leg will be on the upper side, and then patient is on the edge of the bed towards the foot end, and then you ask patient to bend the unaffected leg fully towards the chest and stabilize it, fix it with the both hands. And with this, and you make the figure of 8 there. And we have already discussed how to make figure of 8 in previous chapters. So make the figure of 8 like that, as if you are catching the ball, and then the affected leg goes in such a way that if it is the left leg, it is resting on your right forearm. left leg resting on your right forearm. If it is resting on the left forearm, knee will be straight. You want knee to be flexed. You can be relaxed and just hold it there, just be relaxed. And then I'm going to give traction along the long axis of the femur. While maintaining this traction, I will be going into hip extension. That will give beautiful stretching for the quadriceps muscles. Now make sure the belt is on your knuckles, and moment I abduct, it will lock my hand on the thigh. So you are not making any Dracula grip. It's working like a nice brake pad for the patient, and then you're leaning back using your body weight. So that will give a good traction to not only to the hip joint but also along the long axis of the muscle fibers. Of course, you will need help of another therapist. She will stabilize the patient from there, push it more. So now she's stabilizing and fixing the patient there, and I'm doing the traction along the long axis of the femur. So she stabilized the patient, and then I give traction along the long axis of the femur, and then I go for extension. Is that fine with you?
Yes.
Once it is painful, you let me know. So patient is comfortable till now, and I'm stretching.
Yes. Oh.
Now that is painful. So what I'm going to do is I'm going to add abduction and external rotation. Is that okay now?
Yes.
So that will take away pain, and I'm maintaining the traction and again going for further more extension. Is that fine?
No.
That is painful. So I'm going to add more abduction and external rotation. Is that okay with you?
Yes.
Okay. And then I can give passive oscillations there at the end of the range, or I can sustain it. Now the common mistake while doing this, what you will do is, instead of staying along with the femur, you move too much there. That means you lose the traction component while continuing with the stretching component. You have to give both. You have to sustain the traction and stay along with the femur. That means the patella should be near your umbilicus. It should not go away. Okay? So that's a very common mistake physio may do. So hold it again, and then going there. If it is, once it starts giving you pain, let me know.
Out.
Okay? Go for abduction and external rotation. Is that okay?
Yes.
Okay, and then I'm going further.
Out.
Okay, more abduction, more external rotation. Is that okay? And then in the end range, you hold it there. And while coming back, again you maintain the traction, and then you come back. So let me show you the position once again, how I did it. Made figure of 8. Belt is on your scapula, outside your deltoid, and as if you're going to catch the ball, take the leg resting on the opposite forearm. If it is right leg, it will be left forearm. If it is left leg, it will be right forearm of yours. And then you're not on the popliteal fossa, you are in the middle of the thigh, and then use the body weight, give the traction, maintain that knee flexion, and then you're going into extension along with the femur. If it is painful, go for abduction, external rotation, go further and hold it in the end range, or give the passive oscillation in the end range, and then after 10 to 20 seconds you come back, still sustaining your traction, and then again reassess hip extension. So you're going to compare the examination, that is hip extension, with knee flexion. Please lie down on your tummy. So this is how you're going to check the stretchability of the quadriceps muscles. Hold it there, stabilize it, and then check the hip extension. If you want, you can measure the distance between the lower end of the femur and the table, and then again do it for the other leg and check it. And of course this is going more because I give the stretching on this side. Then compare it with the previous measurement. So you check the stretchability of the quadriceps muscle, stabilizing the hip, holding with one hand, and then other hand going at the lower end, and then you are pulling it up, and compare it with the previous one. If done properly, this gives beautiful results, and it's a must technique in case of mild to moderate osteoarthritis of the knee joint. And in athlete also, this works beautifully for giving them nice flexibility. This technique will also help not only the quadriceps muscle but also the iliopsoas muscle. Why iliopsoas? Because if you notice, we ask the person to bend the other leg towards the chest. That means the pelvic went into posterior tilt. And then we went for the hip extension. So not only the quadriceps but also the psoas muscle, iliopsoas muscle got beautifully stretched. That means this technique will also help in case someone is having hyperlordotic spine because of the tightness of the iliopsoas muscle. And this will also help in lower back pain, anterior hip joint pain, getting muscle cramp constantly in quadriceps muscles. So along with the stretching, you should do the strengthening exercise also for the quadriceps muscle in case you are doing this for the OA knee patient. Of course, in case of severe osteoarthritis of the knee joint, that will be the limitation for doing this technique. And even the elderly patient or patient is having severe osteoporosis or total knee replacement or total hip replacement will again be contraindicated. So check the yellow flags, red flags and the limitation before doing this. Technique must be pain-free all the time, during or even after the technique. It must not cause pain. If by mistake you overdo the treatment, which is very less chance if you're following all the 18 principles, but in case by mistake you do it, give the cryopack, cold therapy immediately after this technique. That should settle down any soreness after the treatment. So this is how you would stretch the quadriceps muscles. Now, next video, I'm going to show how to stretch the adductor muscles in a beautiful way without giving any pain to the patient. And the results are so good, really very, very impressive. Though the procedure is almost the same, but for this, you will need two therapists and you're working simultaneously on both sides. And you'll be needing two belts to fix the patient and to stretch the adductors. This is such a lovely technique, and we are very proud to say that this technique is developed by us in India. Now it is taught worldwide. Other two techniques were developed by Brian Mulligan, but the technique which I'm going to show you is the technique developed and researched by us in India, and now it's a part of Mulligan concept and it's being taught worldwide by all the Mulligan teachers. Hi, in this chapter, we'll be discussing and demonstrating how to increase hip joint abduction or how to treat tight hip adductors. This is a beautiful technique for not only increasing the hip abduction, but even other range of motion at the hip joint. We conducted a research in Capri Institute for this technique, where we did a control study. On 30 people, we did this technique, while on other 30 people, we did conventional adductor stretching technique. And on the group where we did this technique, it's not only the abduction got increased, but also the internal rotation and external rotation, hip extension, as well as hip flexion got increased. That too in a pain-free way. However, in other 30 people, it's only the abduction got increased, and the procedure was also not very comfortable. They had pain while stretching those muscles. So this is a pain-free way of gaining hip abduction and stretching of the adductor muscle. This technique also works beautifully if someone comes with the adductor strain. This technique we have also tried on spastic children. And to our surprise, after this technique, those CP kids could walk better as compared to how they were walking before doing this technique. So this is a beautiful technique even in spastic kids, and you must give it a try on the patient having tight adductors because of either spasticity or strain or lack of activity. Make sure you check the yellow flags and red flags before doing it. This will be absolute contraindication after total hip replacement, or in case of severe osteoporosis, elderly patient, or in case of micro trauma or muscle rupture or the tear in the adductor muscles. At the end of the range, you can give passive accessory movement, or you can sustain the pull and the glide while the person do the active push-ups. You must try this technique. This is a beautiful way of increasing range of motion at the hip joint. As I said, not only the abduction but also the internal rotation, external rotation, flexion as well as extension. So with single technique you are getting all range of motion. And if it is helping your patient, you will do 2 more times. That is totally 3 times you'll be doing, and you can do it on daily basis. Make sure again it is a pain-free procedure. It must not give pain to the patient. Slight discomfort is okay. That also if you are going too aggressive, but make sure you do it in a pain-free way. If it is painful, add more traction and external rotation at the hip joint, as we did for the quadriceps stretching, or in case of hams stretching we did with the flexioning in the previous chapters. So let's do this technique. So as you can see, this technique also needs 1 more therapist. But in case you don't have 1 more therapist, you can let the patient hang 1 leg on one side and you perform on this side, and then alternatively you can perform on the other side as well. But in case you are 2 therapists in the clinic, I suggest you both do this technique simultaneously and get beautiful results. Before doing this technique, obviously you will check the range of motion for abduction, flexion, extension, internal and external rotation, so that you can compare it after doing this procedure. So how do you do that? Again, put the belt on your shoulder and then make the figure of 8 as already demonstrated earlier, as if you are going to catch the ball. Thumb is inside the belt. Both therapists do the same way, and then put the belt on the lower end of the femur on both legs, and then give the traction along the long axis of the femur, and then you be relaxed, and then you gently go into abduction. And let the patient bend his knee and ask him to be totally relaxed. So that's going to be the starting position. In case patient is not having that amount of abduction, you will make the patient sit on corner of the bed, and then you can manage with less amount of abduction also. So luckily this model of mine has good amount of abduction, and we could reach this range easily without giving any technique. So now I'm going to give the traction along the long axis of femur and then going for abduction slowly. Again, make sure you are not going like that. So this will be pure stretching. Don't give stretching at the cost of traction. So you have to go along with the femur. Okay, so you're giving traction as well as the stretching. Maintain that, and once you think you have reached the end range, or if it is painful to the patient, add external rotation. That should be comfortable to the patient. And now, is that okay?
No.
Painful?
Yes.
Okay. Slightly painful or discomfort?
Slight pain.
Slight painful. So you stop there. Now please sit down. Yeah. And now put your both hands in the front. So while you sustain the glide, he will do the push-ups, 10 push-ups, using his arm muscles so that he do not strain his back. Please do the push-ups now and back. And while we are sustaining the traction as well as the abduction in the same range. So this will increase the flexion, abduction, internal rotation, external rotation, as well as extension at the hip joint. 10 times.
Yes.
Go down and lie down. In case the patient is having weak abdominals, maybe you can give some support to the patient, but otherwise patient can simply lie down, or patient can stay in sitting position also. And you're maintaining the traction. Without losing traction, you're putting it back on the bed and simply remove the bed. So what I did, I made figure of 8 and then went inside, giving the traction and then holding it there and then going into abduction on either side. Once you reach there, at the end range, patient says discomfort is there or slight pain is there, ask the patient to sit and use the arm muscles and do the push-ups, so that will help in further increase in range of motion. In case patient is not able to do push-up, that is fine. So the techniques will end where you are reaching the end range. That's it. No need to make patient sit in case patient is not able to sit. It is fine. But if you want to go aggressive, patient is young or the middle age or athlete, then you can ask the patient to sit and do the push-ups. Make sure it is pain-free and then recheck the range of motion after doing this technique. It's a beautiful technique, let me tell you once again, for the hip joint mobilization as well as for treating the adductor strain, and even for spastic children having scissoring gait, it works beautifully. You must give it a try and do it gently, slowly. Check the yellow flags and red flags, do it in a pain-free way. Thank you very much. इस हटा यहाँ से Okay, so these were the 3 techniques, and I discussed about the study we did on spastic children. That was a study done by the Snail ma'am at her center, and I was one of the author in that. And the results were awesome, and in fact, she managed to get it published also in international journal. So it's very privileged and proud to be associated with you, ma'am. And now I believe that these 3 techniques are probably working on Thixotropy kind of concept ma'am gave in her introduction. And excellent techniques. You must try on your all patients. Over to you, ma'am.
So there is a question for you, sir, that is, can you give stretches for more than one muscle at a single setting?
Yes, of course we can. Of course we can. There's
I
no
agree
issue
with
in
you.
that. Yeah.
Completely agree.
But like, it has to be pain free, as I always say, pain
Yeah.
free, pain free, pain free. Slight discomfort is okay, and if it is pain free, it is fine. And if it is painful patient, that means the patient's body is not ready to accept that. And if the patient is having pain, they will not like it, or probably, I do not know if the pain will also increase the spasticity or not. But pain will definitely increase the anxiety, and anxiety will definitely increase the spasticity. So make sure it is not painful.
So I would just like to share what happened to the boy whom I showed on the first slide. You'll appreciate how things were. This was just last year. He had undergone a shot of Botox, and you can see how he was. That's our little one last year. We had taken a workshop and he had kindly consented and he had come. You can see the way he's standing. He was doing his writing on the board. That was the goal which we had achieved for the session. And if you see him now post, so yeah, you can see him here. That was yesterday when I had seen him, and that was really a very bad shape which he had come to us. I hope you can see the screen because I shared it from another folder.
We are able to see, ma'am.
So this is what I was trying to do. You can see how much amount of gain I have to give him. I have to actually use my entire body. And if we can use techniques which sir had shown on him, I'm trying to work on hip extension. He also has to work a lot along with me. Yes, needless to say, I'm getting a good gain out of it because our post session was wonderful. But what I want to show you all is the moment he comes down, see what happens to him. And that's a very important part of therapy which we should look at. See, he just collapses. There he goes. So there is no eccentric in him. There is no eccentric. So working on muscles with the mobility is a very important part of therapy. Very, very important part of therapy. You can see the same little boy within a span of maybe 9 to 10 months or maybe a year. There's so much amount of static component. The elasticity is lost. He's going into crouch more. So we decided to work. We had a lovely session. I won't show you all the session. I just wanted to explain to you what are the dynamics of the musculoskeletal system as we call it. So coming to what exactly we did and how we worked is something what is interesting. And as Sir said rightly, go back to my presentation for a few more slides before we think whether we can walk the new way. We should. This is really worrisome for me. I don't like Google Slides. I hate Google Slides for this. Yeah. So, but then I need to go to the slide. How do I do it? View, present. Present. My struggle comes here. No, I'm going. Okay, there you go. You can pause, otherwise वो आगे automatically जाएगा. So this is what we did. Efficacy of different types of malignant
Ma'am, we can't hear you.
Why is that? Just a second. Okay, can you hear me now?
Yeah.
Yeah.
Yes.
So this was the paper which we had published in the journal. So when you're looking at children with spastic diplegia and crouch gait in the GMFCS level 1 and 2, we gave adductor elongation, we gave the bent leg raise, and we gave rectus elongation. This was a part of therapy which was given for 1 hour, 3 times a week for 12 weeks. Okay, we looked at primary outcome measures and secondary outcome measures. So this were the different measures what we used when we did it. And the conclusion was that definitely that these techniques show a potential in improvement in mobility at joints in children with spastic diplegia, with crouch gait, and facilitated improved function. So we definitely need to walk a long way. We need to do research in this way, in this area. You can see this was one of the spastic individual with spastic diplegia who was around 30 years old who had approached us, and he had come to us, and now he is now driving. He's living a good life. He's married. This is another kiddo. She's also done very well. So she was another case. And you can see we are giving the techniques. I had to learn the techniques using the belt. It was very exciting to learn the techniques with Sir. But very importantly, one has to understand that before doing any sort of manual therapy, you need to have a knowledge of normal anatomy and physiology, particularly regarding ambulation, a very good understanding of functional pathology, which is present in cerebral palsy. You have to set realistic goals and objectives for treatment that are shared commonly with the patient, family, and others concerned. Your knowledge and ability to carry out any of these treatments that are required, and you need a facility with resources that can carry out the necessary. So all those bells, the plinth, etc., etc., is a must. So the research question is it effective? So we looked at research, what was available, and systematic reviews of manual therapy in children and adolescents claim that only 26 studies are there. So the evidence is minimal. So it is up to us whether we really want to walk the new way. Is it worth? Yes, I think it is really, really worth. Because when you walk the new way, you create a new world and a new plethora of possibilities for the generation or for the population who comes to you for help. So give all and gain all. That is what we believe in. And I'm really, really happy that this is one new way of therapy which we had worked upon and it gave us good gains. So giving this therapy to people would be the way forward, and doing more research is something what I look forward in this new year. Thank you so much, Dr. Deepak Kumar, for being a part of the journey. And